Management of dehydration in severe acute malnutrition. The management of dehydration in malnourished patients requires a thorough baseline assessment and vigilant monitoring, as malnourished children are easily prone to overhydration, heart failure, and poor outcomes. Severe malnutrition complicated with dehydration is a risk factor for mortality from the dehydration itself, or due to fluid overload during therapy, or the associated metabolic or electrolyte derangements associated with it, like hypoglycemia and hypothermia. The process of rehydrating a child with severe acute malnutrition and dehydration involves accurate assessment of the presence or absence of dehydration and of its severity, correction of dehydration using the appropriate fluids, vigilant monitoring for signs of deterioration, and taking appropriate action. For the assessment of dehydration status, some of the clinical signs used in children without severe acute malnutrition become unreliable in children with severe acute malnutrition. For example, the mental state of malnourished patients can be apathetic and irritable. Reduced level of consciousness and lethargy can be due to severe dehydration, but it can also be due to sepsis, hypoglycemia, or hypothermia. Dry mucous membranes are common in malnourished children due to atrophied salivary and lacrimal glands. Skin turgor is commonly slow in wasted, malnourished children due to loss of subcutaneous fat. Please note that these signs are, however, looked for and assessed for response as the patient is rehydrated. The clinical information which helps to support the diagnosis of dehydration in severe acute malnutrition include the presence of a history of watery diarrhea or excessive vomiting. A child with dehydration should have a history of losses. Small mucoid stools do not cause dehydration. A child with signs of dehydration in the absence of watery diarrhea should be treated as septic shock. The ability to drink. Drinking eagerly is a reliable sign of some dehydration. The reduction in urine and the reduction in the rate of nappy changes are also an indication of dehydration. The appearance of sunken eyes, which is recent according to the mother. This is because malnutrition can cause sunken eyes due to loss of subcutaneous fat. But if the appearance is recent and in the presence of watery diarrhea, then it's most likely due to dehydration. Cold hands and feet that are associated with an absent or fast, weak radial pulse may signify severe dehydration with shock. Please note that this guideline is for the correction of dehydration in a patient who is not in shock. Whenever possible, a severely dehydrated, malnourished patient should be rehydrated orally unless there are overt signs of shock, which are a lethargic or unconscious patient, cold hands and feet associated with a rapid or weak or absent radial pulse, and a delayed capillary refill time of greater than 3 seconds. The use of oral rehydration solution for the severely malnourished child, Risomal. Use oral rehydration solution for the severely malnourished child, Risomal. If Risomal is not available, you may use half-strength WHO low osmolarity oral rehydration solution with added potassium and sugar. Please note that Risomal should not be used in patients with severe profuse watery diarrhea or cholera. The steps to take when rehydrating a severely malnourished patient. Measure and record the baseline. Record the weight, use an accurate standardized scale, document baseline heart rate and respiratory rate, and mark the age of the liver. To calculate 50 to 100 milliliters per kilogram body weight of oral rehydration solution and give over 12 hours. Start with 10 milliliters per kilogram per hour and reassess after 2 hours, noting respiratory rate, heart rate, weight, liver size, signs of dehydration, and the general clinical condition. The subsequent management after the 2-hour assessment is determined by the clinical findings as outlined in the table below. Observation is at 2 hours, and if there is continued weight loss, then the action to be taken is that you must increase the rate of administration of Resolmal by 10 milliliters per kilogram per hour, and then reassess after 1 hour. If there is no weight gain, increase the rate of administration of Resolmal by 5 milliliters per kilogram per hour. If there is weight gain and deterioration of the child's condition, then the diagnosis of dehydration is wrong. Stop rehydration and start the child on F75. If there is no improvement in the mood and look of the child or reversal of the clinical signs, the diagnosis of dehydration is probably wrong. Either change to F75 or alternate F75 and Resolmal. If there is clinical improvement, but there is still signs of dehydration, continue with the treatment until the appropriate weight gain has been achieved. Either continue with Resolmal alone, or F75 and Resolmal can be alternated. If there is a resolution of the signs of dehydration, stop rehydration treatment and start the child on an F75 diet. Feeding. Breastfeeding should not be interrupted. Begin F75 as soon as possible and administer orally or by nasogastric tube, usually within 2 to 3 hours after hydration, or immediately if the child is alert and drinking well. Skip the Resolmal during the hour you give F75. Continue reassessing the patient hourly, noting respiratory rate, heart rate, weight, liver size, signs of dehydration, and general clinical condition. Stop Resolmal if new signs suggesting fluid overload, such as raised jugular venous pressure, basal crepitations, worsening edema or puffiness, or increased heart rate and respiratory rate. When rehydration is complete, as evidenced by weight deficit corrected, the child is no longer thirsty, is passing urine, and any other signs of dehydration have corrected. Note well that you must always consider the possibility of concomitant septic shock in very sick malnourished children with features of dehydration. For the management of hypovolemic shock and septic shock, refer to the video on shock in malnutrition.